Adolescent Idiopathic Scoliosis. The human spine is a unique structure, not in terms of its anatomy, but in the way it is loaded, which differs considerably from other vertebrates, including the bipedal ones. Axial forces are working on each spine in nature and compress the vertebrae and discs. In addition, the anterior shear force is working on the spine. An overload of axial forces can result in Sherman's disease, and an overload of anterior shear forces, also present in certain areas of the human spine, can lead to spondylolisthesis. The anterior shear force enables the facet joints to play an important role in providing rotational stability to the spine. But unique to the human spine are certain vertebrae with a backward inclination, which is subject to posterior shear loads. When the anterior shear force becomes negative, the stabilizing mechanism of the facet joints is lost. The posterior shear loads decrease the rotational stiffness of the segment and make the vertebrae therefore more prone to develop a progressive rotational deformity like scoliosis. In scoliosis, vertebrae are rotated away from the midline, resulting in a three-dimensional deformity of the entire trunk. Quantifying the vertebral inclination for a group of healthy subjects, a significant difference has been found between male and female subjects. The average female spine is more inclined during the growth spurt compared to boys at the same stage of development. This explains why initiation and progression of adolescent idiopathic scoliosis are more prevalent in girls around puberty. The vertebrae of an average healthy adolescent spine with a normal organ anatomy are slightly but significantly rotated to the right in the mid and lower thoracic area, in contrast to patients with situs inversus, where the average rotation is a mirror image of this. This supports the hypothesis that the direction of the spinal curve in scoliosis is determined by a built-in rotational pattern that the spine exhibits at the time of onset. Significant differences in the sagittal profile can be observed between a beginning thoracic and lumbar scoliosis. For thoracic scoliosis, a significantly longer posteriorly inclined segment and steeper cervicothoracic posterior inclination was observed, as compared with both lumbar scoliosis and controls. In lumbar scoliosis, the posteriorly inclined segment was shorter and located lower in the spine. This supports the theory that differences in underlying sagittal profile play a role in the development of different types of idiopathic scoliosis. Investigating the true morphology of a scoliotic spine, we observed, in line with previous authors, that all curves in scoliosis, structural and non-structural, exhibit a longer anterior length than posterior. Our research has demonstrated that this anterior lengthening is not specific for idiopathic scoliosis, but occurs in a similar manner in other types of scoliosis. In the thoracic spine, this is of course opposite to normal kyphotic anatomy. What we found additionally is that the apical zones contribute most to this excess anterior length, whereas the proximal and distal junctional areas are more or less straight. Furthermore, the additional anterior length is predominantly in the disc, not in the bone, making a primary growth disturbance less likely. This has consequences for corrective surgery. Either posterior lengthening or anterior shortening has to be applied in order to obtain a harmonious restoration of the sagittal alignment.